Okay, so diagnostic tests are important because it decides whether we have a hemorrhagic or ischemic stroke. It's going to change our treatment, right? If it's ischemic stroke, we can fix it, right? As long as we know, as long as the last known time well is reasonable, right? And what is reasonable is 4.5 hours for the most part. Okay, we do have another option out there within 12 hours, but 4.5 hours for thrombolytics is what we want. So we identify, oh, grandma was started, having this slurred speech when at 5 a.m., let's say. All right, so after 9:30, it's too late, all right? But if it's before that, we have the option to see if we can treat it with medications, right, thrombolytics. But do we want to give a thrombolytic to bust clots and someone has a bleed in their brain? No, that's going to make it bleed more because you made your own clots to stop the bleed, and then you give a thrombolytic to bleed more. All right, that's not a good idea. So how do we know it's safe to give these medications? There's no bleed. Right? So that's the whole purpose of the CT scan, is to say, hey, there's no bleed on the CT scan. The other purpose is to show that there's no ischemia on the CT scan. So that's weird. How do I know it's ischemic stroke? You don't for 12 hours. So it takes about 12 hours for ischemia to show on the CT scan. So what we want to see is a CT scan that is perfect, ideally. All right? That's going to tell us that we have a ischemic stroke, we have symptoms of stroke. They have a CT scan that shows nothing. That's great. If the CT scan shows ischemia, you're lying about grandma. It wasn't 5 a.m. It was probably 5 p.m. Right? Because it takes 12 hours for that stroke to develop. Does that make sense? All right. So CT scan is done to make sure that it shows no ischemia and no hemorrhage, because if it does, A, hemorrhage is contraindicated for thrombolytics, but also B, that means it's been about 8 to 12 hours at least for that ischemia to develop. You could do an MRI. MRI is actually much more accurate, but it takes about an hour to get there and back, and you have to do an MRI checklist. You have to ask if they've ever been shot before, or they have these wires, or these like pacemaker, and you have to say, hey, is that pacemaker MRI safe? Go ahead and call the company that the pacemaker was inserted in 1975, and then go ahead and check to see if that's good. And then you have to say it's a whole ordeal to get the MRI. All right, but it's much safer than a CT scan. It actually is going to show very, very specific. It can show early ischemia even. All right, the labs to make sure there's nothing mimicking a stroke. Like we said, like infection could be mimicking it. There could be maybe electrolytes might be off, but also specifically, do they have a blood sugar that is abnormal? And we do point of care blood sugars. We don't really need to go send the labs out and then wait for it to come back, but we can do a blood sugar right then and there. We do a drug screen to see if they took cocaine or meth or something like that. They took a depressant of some sort, or we can see if they have ETOH on board. An echo, what's the purpose of looking for an echo? Strokes are caused by a cardioembolic origin, right? So it embolized from the cardiac. It came from the cardiac chambers of some sort. They might have a valve issue, or they have a thrombus in the left ventricle, or they might have AFib. So looking at the echo will let us know, hey, that's the reason for your stroke. Okay? Is there vegetation or a clot growing? And then a carotid ultrasound. Why do we look at the carotids? Because the carotids can get occluded, and that's going to cause a pretty significant stroke if the carotids, because there are only two carotids, if one of them gets shut down, then that whole side is going to be done, all right? And then a 12 lead. That's going to look for AFib, right? It's going to let you know something's going on. And here's AFib right there, and there's AFib in real life. So you can see the atrium is fibrillating, right? And then it's not going to, the blood is going to pool, and it's going to cause a clot to form. Okay, so the bottom right corner, that's Med-Surg 3, where you learn about the timing. It's like, oh shoot, got to get a stroke in this time. I got to get the thrombolytic in this time. Right now, we're just going to be introduced saying, hey, they need a CT scan. It needs to be negative, and I need to give a thrombolytic. All right, so treatment for strokes. All right, so thrombolytics are for what kind of strokes? Ischemic. Ischemia on a CT scan shows up gray. That's why I put gray there. Right? So thrombolytics are our goal, as long as it's been less than how many hours? Less than 4.5 hours, right? Why 4.5 hours? Why not 5 hours? Why not 4 hours, right? So 4.5 hours is when you have cross-linked the clot, right? You have made the clot more firm, right? So your body makes a clot and it's just settling. It's like drying out. If you ever made clay before in art class, right? And it has to dry, right? And then you have to put it in a kiln, right? So to make it cured, right? Everybody had that experience in art class, right? So the kiln piece is the 4.5 hours. It's going to the kiln, and you're not going to break that clot no matter what. That TPA or thrombolytic is going to be ineffective, right? And the reason why it's ineffective, and it can also start causing, it's going to go to that clot and try to bust it. It's like, oh, can't do this, and it's going to start busting other clots that you didn't want busted. Okay, because one of the major side effects of this is bleeding, because you're busting all clots. It can't just go, oh, I'm going specifically to the MCA. Here I go, right? It's going through the whole body. You're giving it IV, right? You're drying it up and you're giving it IV, and it's going to go into the vein, and it's going to bust all clots on the way, right? So it is a precursor to a natural found element of the coag cascade that breaks down clots, which is plasmin. All right, so we provide like TPA, for instance, which will break down that clot for us, that fibrin mesh, and that will then release all the platelets, and hopefully you'll get flow on the other side of the vessel. Okay, so there's a new guy on the block now. It's called TNK, so it's tenecteplase. It's also a thrombolytic. It's the same stuff, 4.5 hours. Blood pressure needs to be controlled before you give these medications, because what if the blood pressure is like 200 and you give medication that's going to bust clots? Well, now you can pop through an artery, and then that's going to be a bad story, right? So blood pressure we'll talk about next, but tenecteplase is much easier to draw, right? The math is much easier than my math, right? It's easier to calculate how much to give, and you can give it immediately, right now, right? Whereas TPA, for instance, you have to draw it up and calculate 0.9 per kilo. Don't give more than 100 milligrams. Make sure you give it 10% now, and the other 90% over 60 minutes. It's ridiculous, right? Mental math can be hard, and you have to have a pharmacy mix it for you, and they have to bring it up. They have to watch you give it to make sure you can do math, right? It's like, no, my left brain's not working, right? So it's a whole issue. Whereas TNK is easier to give, and it has, the outcomes are identical, but you get more TNK delivered at least. But before you give a thrombolytic, you got to make sure the CT has what? No bleed and no ischemia. And also you better make sure the sugar is normal, because these thrombolytics are not just like, oh, just like saline. I guess it didn't work. No, it has a 7% mortality. That means out of, if there's 30 of us here, 3 of us will die if we get TPA right now, right? Whereas you give vancomycin, all of us, maybe like half of us will die, or not half, like half of 1% would die. It's a very, very small risk, right? Whereas TPA is extreme risk. You can die from this medication. So they have to sign a what? They have to sign their life away, literally, all right? They have to sign a consent to make sure that it is, that they're okay with this, right? Are you okay getting this medication? You can die from the medication, right? 7 in 100 people, or 7 in 10, you could say, not 7 in 10, was it like 2 in 10, or whatever it is, right? The math's hard, right? So it's less than 1 in 10 will die, right? So if I give it to 10 of you, 7 of those will die. Anyway, so that's the idea, all right? So it has a really, really high mortality, but then the salesmen, they say, hey, but you may never be able to ride your bike again. You may never be able to to walk again. Would you rather do that or die? It's like, oh, I guess I want full function if that's a possibility. So that is so people usually opt in for it. Okay, so that's the idea behind, or that's the significant side effect of thrombolytics. And then Angelina Jolie is also a side effect as well of these. So before this medication be given, the blood pressure has to be decent, and what's decent is less than 185 over 110. That's acceptable. And then after the medication is infused, you have to keep that blood pressure under 180 over 110. So that has to be sustained for at least 24 hours. You have to keep that blood pressure controlled. If you don't, it can pop the vessel and make you bleed even more. Okay. So we do a stroke scale before and after to make sure that their stroke's not getting worse, because why would their stroke get worse if you're given a medication to bust the clot? Because it has a risk of hemorrhagic stroke, right, and death. So we have to assess that very, very closely. Okay, you don't have to know the frequencies on this, but it's very, very frequent. You're going to be monitoring them after they get this medication. And for 24 hours, make sure they don't fall. Make sure they don't have any kind of vena punctures, arterial punctures, procedures. Basically, they are, once they do that, they are not blessed, but they are protected for 24 hours. You should not do anything unless it's like an absolute emergency. Okay, no Foley catheters, no sticking, no nothing. Okay, and then a CT is going to be done in 24 hours to make sure that no bleed happened. Right, so make sure that it didn't develop a hemorrhagic stroke because of the medication. And then after 24 hours, we can start giving the therapy for every ischemic stroke, which is aspirin. And then if they're in the hospital, they might be immobile. So we got to give them what kind of prophylaxis? VTE prophylaxis. And we do pharmacological and mechanical. So mechanical is what kind of VTE prophylaxis is that? SCBs or stockings, and a pharmacological way would be what? Be heparin or enoxaparin. Those are anticoagulants. Aspirin is a antiplatelet, and that would be used for the stroke in general, right? So if someone has an ischemic stroke, is not getting thrombolytics, you get that in there as soon as possible, right? But they can't swallow. What do? You get it in there, per rectum, right? You put it in and you make sure they get that aspirin on board, right? So they need to have aspirin within 24 hours is a national mandate for someone who's not getting thrombolytics. If they're getting thrombolytics, they'll say, okay, after the 24-hour mark, get a CT scan, no hemorrhage, then go ahead and give those medications. Okay. We do have another option out there. If they don't get thrombolytics, we can do what's called a clot retrieval, or we can go in with a little tube and we go all the way up, all the way into the MCA and yoink out the clot. Just go ahead and just grab it. You got up to 12 hours to do that. All right, 12 to 24 hours. It depends on the center. All right, and then BP management. We mentioned the BP last time with hypertension. Hypertension in general, they have no stroke or no dissection, 25%, right, over 24 hours. For strokes, it's different, right? And it depends. There's three options. So when you're studying this, you have to think of, you have to think a little algorithm. So if they have a stroke, oh shoot, now I got three options. If they have a stroke, how do I fix the blood pressure? Well, if the blood pressure if they're going to get thrombolytic, it's 185 or 110, right? That's where you bring down the blood pressure. As long as less than that, you're golden to give the medication, and that's where you have to maintain it for 24 hours. The next option is you have an ischemic stroke, but you're not giving thrombolytics. So if you're not giving thrombolytics, you have an ischemic stroke, how do you fix the blood pressure? You don't. It's called permissive hypertension. You don't treat it until it's over 220 over 120, right? That is when you will say, okay, it's 225, 240 systolic. Oh, now I'll get off my seat. I'll give some medication. I'll give some PRI medications. That's when you would treat an ischemic stroke. And why is that? Why do you want a blood pressure of 220 over 120? Isn't that like a hypertensive crisis? Doesn't hypertensive crisis cause hemorrhagic strokes and ischemic strokes? They do. But if you imagine, here's our MCA territory, and here's our ACA territory, right? And we have a stroke, let's say, in the MCA. All right, so we have a stroke over here. Let's choose a different color. We got a stroke in our MCA right there. Now you're trying to perfuse this area right here. And your only way to perfuse it is A, to get enough pressure past that clot to feed it, right, which is 220 over 120. Or on the other side, you're trying to perfuse it through the ACA, through the collateral circulation. So you want a great blood pressure for at least 24 hours. All right, so that's for ischemic strokes. Hemorrhagic strokes, if you did that, you're going to bleed and bleed and bleed. So hemorrhagic strokes, we switch gears. Hemorrhagic strokes, you get it down within about 2 to 4 hours. You get it down to like 140 to 160 systolic. All right, so that's the idea with blood pressure and strokes. So you have to know as a new nurse, because it happened to me, I had to call the doctor and they told me, hey, go ahead and bring the blood pressure down. And I was like, well, I hang up the phone, I was like, shoot, it's an ischemic stroke. I thought you were supposed to get the blood pressure better. So I called him back. I said, why are you calling me? It's like, because you have an ischemic stroke. I did tell you that, but it's an ischemic stroke, so where you have the blood pressure at? So 220 over 120 for that first 24 hours. All right, and then we can get some platelets on board within 24 hours for like a regular old ischemic stroke. Otherwise, if you've got thrombolytics, it's after 24 hours. We want to maintain everything normal, right? So no changes in O2, no changes in CO2, no changes in temperature, no changes in blood pressure. We want to keep everything great. All right, blood pressure is a little asterisk there, but everything else needs to be absolutely great. Otherwise, what happens if you don't get oxygen to the brain? That area of the brain will do what? It will start to swell, and it's going to swell inside of a closed cranium, and it's going to cause even more lack of blood flow to the brain. It will cause that ischemic stroke, for instance, to get worse, and that will then lead to a hemorrhagic conversion. which is a significant side effect of, or a complication of, a ischemic stroke. Okay, so a large ischemic stroke can turn into all this edema here can then convert into a hemorrhagic stroke. So it was gray initially, which is ischemia, and it turns all the way into a hemorrhage. So cerebral edema is, gets more and more swelling within the brain, can lead to what's called brain herniation. The brain can move, right? But it's in a skull. It can't move many places. The only place it can move is out, right? So it can herniate downward and out through the foramen magnum, which obviously is not very survivable, right? So it's very important that we keep the oxygen normal, we keep the temperature normal, we keep the blood pressure where it needs to be, we keep the CO2 where it needs to be, and the pH where it needs to be. All these things need to be normal for a stroke. And then aspiration pneumonia. Why do they have aspiration pneumonia as a complication? Because they might have decreased LOC, especially the basilar artery stroke, but the cranial nerves for swallowing. What cranial nerves are used for swallowing? 3, 4, and 6? No, that's for the eyes. So 9 and 10 and 12. Those are all for swallowing and articulating speech, but also the tongue movement, right? Also, so those cranial nerves might be involved with what kind of strokes? Would those cranial nerves be involved? Well, the basilar artery stroke. So if you have a basilar artery stroke, you have risk of aspiration pneumonia because the cranial nerves don't work. But if you have an MCA stroke, right, you have dysphagia because the temporal lobe, which feeds the tongue, right, the sensation and motor function of the tongue, that doesn't work. So there's, so MCA strokes lead to aspiration pneumonia, basilar artery strokes lead to it. Does a PCA stroke lead to it? Maybe if they can't see, but not quite. Okay. So aspiration precautions need to be implemented. So what does aspiration precautions include? That's where they are sitting upright, they are not distracted, so they are focused on their meal, right? Make sure that they are not watching Wheel of Fortune or Jeopardy while they're eating, right? So like we park every stroke patient in front of Jeopardy. You want to watch something while you eat, right? So they can listen to something, that's fine, but they shouldn't be distracted. They should be, if they need a swallow eval, or you can do one, but we need to have an expert do it. Who's the expert? A speech language pathologist. All right, and then they have these deficits which can last with them for a while, and they may recover with physical therapy. They may recover with an SLP outside of the hospital, but oftentimes these are permanent deficits or deficits that have a residual effect. So there's significant fall risk, especially if they have an ACA stroke. That means their legs don't work good, right? They could have weakness or paralysis. They could have spatial neglect. So why would someone that has homonymous hemianopsia be a fall risk? Because they neglect one side or the other, right? So if they have a right MCA stroke, which side would they neglect? The left side. It's contralateral. It's contralateral homonymous hemianopsia, right? So they ignore the left side. So the whole left side is not seen, right? It's not like half their vision is dark. They have a cropped inversion. So what do you have to teach them? You have to teach them to scan their head. They're going to look pretty silly, right? They're going to scan their head to make sure they are looking at the whole environment. Okay. And dysphagia we mentioned, incontinence can occur, especially with which kind of strokes? ACA strokes, right? And then immobility. So immobility can happen because of contractures. They don't move their arm, they don't move their leg. They get bedbound. When you're bedbound, you have a lot of complications of immobility. So on the right here, bottom right here, we have a lot of complications that can occur because we are just laying in bed. So you can think of head to toe, they get delirious. That's not good. That can be a fall risk. They can lose their vascular tone to the baroreceptors. So when they do stand up, the baroreceptors don't respond, and blood pressure doesn't support their walking. So that can make them fall. And then we have being in bed itself. You start breaking down bones, right? You use it or lose it. So you lose the muscles, you lose the bones. That's a fall risk. And then you lose the bones, the calcium wilts away and it goes in the kidneys and causes kidney stones, and then that causes UTIs, and then that causes kidney failure. It's all a downward spiral when you're not able to mobilize. So mobilization is a really important way to prevent these complications if able. Okay, and then you get pressure ulcers. Now pressure ulcers are a problem. Range of motion is impaired, so they can get contractures, and now you're contracted even more, and now you're immobile even more. And you're going to have VTEs that develop. So you get venous thromboembolisms, then you get another stroke, and then now you have more immobility, and then you have a higher risk for more pressure ulcers, and more pressure ulcers, more infection, and then you're in bed all the time, so now you're not breathing good. Nurse didn't give you the IS, and now you have atelectasis, and you get pneumonia because of that. It's called atelectatic pneumonia, and then you decide, oh, I can drink just fine, and then you get a aspiration pneumonia. So when you get immobile and bedridden, you have all of these possibilities as a decompensation. When people and older people especially get bedridden, it's a downward spiral. They're not going to get better unless you have active intervention. And you're not going to have a great state of mind. You're going to be depressed because of this, right? And then if they do discharge to prevent a further stroke, we're going to do everything we did for ASCVD, right? And same thing we did for CAD, and same thing for PAD. We do the ABCDE plan. We give statins to prevent atheromas from growing. We give DAPT for about 3 to 6 months or so, and depending on how big the size is. And then if it's embolic, like an AFib, well, you're going to be discharged with a 10A inhibitor. All right, so this, the idea with a ischemic, or any kind of stroke really, can be the complication there. All right, so this is another example here.
Also,
this is what a stroke looks like. She's a news anchor that started having symptoms of a stroke on live TV.
Today at the event.
As you can tell, she's having a hard time getting the words out. News outlets reported that she was having some vision loss and numbness and tingling on one side of her body. And during that moment, she could tell that something was wrong.
I'm sorry, something is going on with me this morning, and I apologize to everybody. Let's just go ahead and send it on over to meteorologist Annie Brown.
When she went to the hospital, doctors told her that she was having something called a transient ischemic attack. This is still a stroke, but it's a short-lived stroke that resolves on its own without any medical intervention. And sometimes it's a sign that something bigger could be going on, and it warrants a further, more extensive workup. In the event that you think somebody might be having a stroke, remember the mnemonic BFAST. It stands for balance issues, eyesight changes, facial droop, arm weakness, speech deficits, and time. Time means time is brain, meaning the longer you wait, the more permanent the deficits could be. The sooner that a stroke is caught, the sooner we can resolve the stroke and the better prognosis the person will have. So if there's ever any concern that someone might be having a stroke, it's always safest to call 911. Have you ever seen anything like this before? Comment below and let me know.
Comment below. All right, so hemorrhagic stroke, we got 2 slides on this and we'll take a break. So hemorrhagic strokes, this obviously is the worst kind of stroke, worse than ischemic stroke. It can happen from a large ischemic stroke. A huge hemispheric ischemic stroke can lead to this. Or we have someone that got thrombolytics for their regular ischemic stroke can lead to this. The number 1 cause is hypertension. Hypertension causes ischemic strokes, right? Causes the lacunar ischemic strokes. But hypertension can just burst through the vessels and start damaging the different nuclei throughout the brain and the different regions of the brain. And the vessels are vessels, so the MCA can hemorrhage, the ACA can hemorrhage, the PCA can hemorrhage, or the basilar artery can hemorrhage. So it's the same symptoms. All right, so large ischemic stroke mentioned, amyloid angiopathy. That is Alzheimer's disease. So Alzheimer's disease is a risk for hemorrhagic strokes. And anticoagulants, especially warfarin. Someone gets warfarin and they come with a head bleed. What's the treatment? Vitamin K if you want to fix it tomorrow. FFP if you want to fix it in 4 hours. You want to fix it right now, you got to fork over 10K for PCC, prothrombin complex concentrate. So that's the fix for that. And if you're going to hold all anticoagulants, obviously, all antiplatelets, all anticoagulants are absolutely held with a hemorrhagic stroke. So it can be intracerebral. That means here's the cerebrum, right? And it's actually, yeah, intracerebral is, misspoke here. That's intracranial. Intracerebral is inside the cerebrum or cerebellum. You have a hemorrhage, and you can hemorrhage around that area, which is a subarachnoid hemorrhage. So subarachnoid hemorrhage is where that space is called the subarachnoid space. It can bleed into that space because aneurysms can pop. Right? When an aneurysm pops because of hypertension, that's going to pop into that space, and it's very, very irritating, and it's going to cause a extreme headache, and you're going to feel that pop. It's called a thunderclap headache. It's the worst headache of their life, right? It feels, and what does it feel like? Like a thunderclap. It's like, how do you know what a thunderclap is? What is the clap of a thunder? Anyways, it's a pathognomonic reason for subarachnoid hemorrhage or aneurysm. What does pathognomonic mean? It means when you hear that word or that symptom, it's always that disease process. Okay. So we'll talk about aneurysms briefly, but non-traumatic subarachnoid hemorrhage, that means the aneurysm just popped. A traumatic one means you got in a car accident or you hit your head or something like that. That's another reason why these vessels might rupture down here. All right, so what are the symptoms of a hemorrhagic stroke? Well, it's just based on whatever vessel was popped, right? So that vessel it gets popped, you're going to have those symptoms. So it's the CVA symptoms of that vessel. And the other piece that's added to this is the pressure in the head is going to get higher and higher more quickly because blood is filling it, right? And the cranium is a closed vault. So this blood gets bigger and bigger and bigger and bigger. That's going to increase what's called the intracranial pressure, right? The ICP. You'll talk a lot more about ICP in Med-Surg 3 and the symptoms of that. Obviously, the symptom is going to be headache, right? It's going to hurt when I've got all that extra pressure inside my head. Okay. And then underlying cause, just get the blood pressure under control, less than 140 to 160 usually. It depends on where you're at. And then within a couple hours, because you don't want that blood to keep pooling inside the brain. Maintain normal everything because you don't want to add edema to the situation. And then the only thing you can really do for this hemorrhage is to pop open the skull, and hopefully it will expand, relieve the pressure. Otherwise, there's not much you can do for this. Another option we could do is we can stick a catheter into the brain. We could cut and we drill a little hole in there, and we put a little catheter and we just kind of collect it in a bag outside, right? We can relieve the pressure that way. It's called an ICP drain. We drain that extra fluid from the brain to help relieve the pressure if we can. You'll talk a lot more about ICP and Med-Surg 3. All right, so our goal here is to avoid secondary problems. All right, so fix the blood pressure. If they have a coagulopathy because of they're taking anticoagulant, we reverse it. Get the sugar under control, temperature, and they're going to be definitely having seizure activity because all that blood is irritating. All right, you can see this huge hemorrhagic stroke in that area of the brain, and it can bleed anywhere inside the brain. Yes, we'll follow the patterns of a CVA, but it can then just be increased ICP. They got change in that level of consciousness. They got this headache happening, and that will then, it's like, well, let's do a CT scan, and you see this huge bleed on the CT scan. All right, so aneurysms. So aneurysms can pop because of hypertension, and when they pop, the blood spills into the space that the aneurysm's around, and the circle Willis is right at the base of the skull, and all that blood is going to start pooling in this at the base of the skull right here, right? So it's all going to pool right there, and that's going to cause a lot of irritation, cause what are called meningeal symptoms. It irritates the meninges. It looks like meningitis, but they have all this increased intracranial pressure as well because all the blood is pooling there, and it's a sudden thunderclap headache, and that's usually the kind of key that, oh shoot, you had a aneurysm that might have popped. You got to go to the hospital right now. It's like, oh no, I'm fine. I'm gonna sleep it off. That's not okay, because if you take aspirin and sleep it off, or Tylenol and sleep it off, or like NSAID or ibuprofen and sleep it off, you're going to bleed more because that puts you at more risk for bleeding, right? So 10 to 15% die prior to arrival to the hospital when you have an aneurysm like this, and then once they get to the ER, 50% of them die, right? And if they make it out of the hospital, if they survived all those odds, 50% of them will have permanent deficits. So it's an incredibly bad outcome when you have this popping of the aneurysm. It usually happens at weak spots in the circle Willis, okay? And that's due to hypertension or induced hypertension like cocaine or meth. That can do it too. All right, the treatment, we can go in there, we can coil it, we can take that weak spot, we can again deposit some coil in there and clot it off so that it will then kind of harden. And the other option is to peel back the brain like Egyptian style and put a little clip in there and over the aneurysm. So that obviously is much more invasive. The other risk is afterwards, all that blood we said was irritating. It can be so irritating that it irritates the vessel to the point of vasoconstriction. It's called cerebral vasospasm. So it can vasospasm and close shut. And how do we stop that? With a calcium channel blocker. We vasodilate so that it can't react to that irritation. And it's only one specific calcium channel blocker. It's called nimodipine. So nimodipine is the only one that we give for cerebral vasospasm. You'll never see it given for anything else. Nicardipine is different. Nifedipine is different. But nimodipine, those are all calcium channel blockers. Nimodipine is only for cerebral vasospasm prophylaxis.